So thank you very much to both of you for those great talks, and it's a great introduction to the conference. Please, everyone, if you want to ask questions, you can do it via the group chat, and I will try and relay those questions and put them together. So Adeeba, can I start with you, because I think we often hear about the need to stop stigma, but is it actually possible? What actually are we aiming for? You know, I think there's been stigma against many things in the past, and it's just continued over hundreds of years. So really, what are we trying to achieve when we say reductions in stigma as regards HIV?
Yep, you're absolutely right, Mark. And obviously, it's the Achilles heel of the AIDS response, the HIV response. And basically, I think what we're trying to achieve is this negativity towards people living with HIV or people who, are at risk for HIV because they're a member of key population, whether real or perceived, that that can, stop them from coming forward or stop them from accessing treatment and care and prevention services. So it's something that is very difficult to measure, the impact of, and I think that's basically it.
Okay, so one of the things that's come up quite a lot over recent years is not only the stigmatization from others, but also a kind of self-stigmatization. So do you have any views on how we can deal with that better, to try and prevent the kind of self-blame for HIV?
The so-called internal self-stigma. Yeah, so I think that comes also with education and really learning more about the disease itself, having better knowledge about the disease, but also in terms of building resilience and confidence in overcoming this internalized stigma.
Great. And then there's, along with all of us, congratulations for you becoming the first Asian as president of the IEF. But there's quite a difficult question here. What are your plans in terms of policy advocacy to change things amongst Asian policymakers?
Yeah, so this is, as I alluded to, it's going to be one of the toughest. For 40 years we've been trying to do this, and I think in the last decade or so, it has gotten even, the region has gotten even more conservative. So it basically, again, it's education, it's partnership. It's not something that we can do alone, IS can do alone. Recently, we partnered with Unite, which is a group of parliamentarians whose goal is to address infectious diseases, and here IES had the Unite seminar with parliamentarians. We had a session on people who inject drugs, for example, and we need to continue to work with other large and small organizations, because this is not something that is going to go away overnight. So partnerships, education, and really focusing on countries, including our own country at one point, was really moving forward with the issue of decriminalization of injecting drug use. But we've had a bit of a political turmoil recently, so that's taken a back foot. So I think we just have to keep pushing at it, and just like with everything else, working with many stakeholders and collaboratively, and not to let up on the education of not just people at risk, but people living with HIV and policy and decision makers as well. But one of the key areas for one of the large groups that we need to tackle is, of course, healthcare workers ourselves. As our study showed, medical students in my own school, harbor a high degree of stigma. So advocating for including interventions or education to reduce stigma, contact or exposures for these students, and doing, to institutionalize interventions that have been proven to work through curricular changes has been one of the work that I've been doing, at least locally, and hopefully we can expand this regionally, if not globally as well.
Okay, and we're going to have questions for Nittaya. I think we can have in the future session. So as we've only got you for a short time, another question for you, Adeeba. How do we actually measure, or can we tell that there's been a decrease in stigma? So how do we measure, hopefully, our own success?
I guess this is one thing that we have not been very good at, and there are groups that are trying to do that in a more systematic way. At the policy level, what would be obvious if there are policies and laws, and the George Washington, the HIV policy group has recently put out a HIV policy, what do you call it? That they've done very nicely a HIV and law policy measure that the George Washington group has done. And so hopefully that will help us measure HIV-related laws and policies globally. At the individual and institutional level, I guess it's something that research and studies will need to be done to look at if there's been decreases in stigmatizing behavior.
Great. So we've been given a little bit of extra time. So Nittaya, can I ask you, there's a question about, and I find this interesting, that you say there's still virus in the genital fluids, but you can't transmit. And I'm interested in that because we had a meeting yesterday where we were giving out research grants, and there was one looking at this. And the message from the community is that you need to stop being negative about U equals U and trying to prove it wrong. It's now, you've shown us the study, it's a proven thing, and we now need to leave that and just promote the idea and not try and bring negative judgment into it. So your views and your explanation, I suppose.
Mm-hmm. I think that there are so many studies demonstrating that we can still identify virus in genital fluids, even when people have undetectable viral load in blood. But what we haven't had, and I don't think that we will ever have, is that we document the transmission from that level of viral load in the genital fluid that cause transmission to other people. Because if you look at the literature, you will see that it's up to like 15 to 20% of people with undetectable viral load in blood who will still have from time to time detectable viral load in the genital fluids, but we never see any case of transmission because of that detectable viral load in genital fluid. So the explanation could be that because these are defective virus, or that because of the level in the genital fluid, which we still don't know what will be the level that will cause the virus to be able to transmit to someone in genital fluids. We're not talking about the level in blood, right? So, I mean, the point here is that we, as a healthcare workers, are trying to find knowledge gaps that will defer us from implementing what we already know. And I think that I mean, stigma discrimination can caused by the lack of knowledge, inadequate knowledge. But at the same time, I think the more important thing is that are you sure that you are not asking this question because you have this implicit stigma, because you think that people with HIV may not be responsible enough to have safe sex if you are telling this U equals U to other people. I think that's probably more important for us to explore. And yes, if it is feasible for you to do more research to prove that that detectable viral load in genital fluid can or cannot be transmit HIV, I think that's great. But what we know now is that we haven't seen any transmission because of that. And why wouldn't you be dare enough to talk about U equals U? And I feel that this U equals U stigma is actually sexual stigma. And if you link this U equals U to things related to condomless sex, then the discussion will not go anywhere.
Great, thank you. And Adeeba, final question for you. And I'm sorry, I'm not sorry, but they do sound quite political. And so please give whatever answer you want. But will the IAS protect community advocates and healthcare providers in speaking the truth in the face of political opposition to U equals U?
Yeah, I think we were involved in supporting Nittaya at the time when she had faced quite significant opposition to the U equals U campaign in Thailand, Bangkok. And basically, Nittaya reached out to the IAS, and we supported her and the local team in the best way we could, with the advice from herself and the local people. So the answer is yes, we will do as much as we can within you know, the limits of the organization to support our members.
Great. Thank you very much. There are lots of other questions, and what we're trying to do is run them through appropriately in the next couple of sessions. But I'd like to thank both of you. I think that's a fantastic, stimulating start to the conference. And we'll move on now to the next part of the meeting.
Thank you.
Thanks, Mark. Thanks, Nittaya.
Thanks, Adeeba.
Thank you both. Really, really good. Really good. Thank you, Adeeba.
Bye, Mark. Bye, Nittaya.
Thank you very much.
Thanks. Bye.
Is the